Good evening, everyone, and welcome to October's edition of the Scleral Education Society webinar series. My name is Dr. Ashley Tucker, and I will be your moderator for this evening. It is my pleasure to welcome Dr. Gregory DeNaeyer on his talk about scleral lens management of the keratoconus patient. Dr. DeNaeyer practices at Arena Eye Surgeons with an emphasis on specialty contact lenses. Dr. DeNaeyer was a co-founder and past president of the Scleral Lens Education Society and is a fellow of the American Academy of Optometry. He's a contributing editor for Contact Lens Spectrum and a contributor to Review of Cornea and Contact Lenses and Optometric Management. Dr. DeNaeyer has lectured internationally on specialty contact lenses and was previously named GPLI and Scleral Lens Education Society Practitioner of the Year and the recipient of the ISCLS Herschel Medal. All of Dr. DeNayer's financial disclosures have been mitigated. So just a reminder of a couple of things here. So if you have questions throughout the webinar, please feel free to put them in the Q&A feature and or the chat feature. We'll be looking through those and posing those questions to Dr. DeNaeyer at the end. In order to get CE credit, you must remain online for a minimum of 15 minutes for COPE approval, and attendees are welcome but not obligated to stay for the Q&A. So something that's new this year, please feel free to go ahead and download the Arbo app, the OE Tracker app, in the Apple Store or the Google Play Store. If you don't have this app already downloaded, the QR code will not work. So please make sure you have that. At the end, I'll go through these instructions again, but you'll open the app, verify that your personal information is correct, and then touch the scan QR code, and then that will allow you to scan the QR code. You cannot just scan the QR code without the app, so please make sure you have it. And then don't worry, if you can't get this to work, CE certificates will be emailed within 2 weeks. All right, that is all I have. Well, let me just tell you about next month, just really quick. Please join us next month for Dr. Stephanie Tran's talk on to surgery or not to surgery or to scleral. So I will stop sharing and let Dr. DeNaeyer take it away.
Okay. Thank you, Dr. Tucker. Appreciate that. Can you see my slides okay?
Yes, we can see them.
Okay, perfect. Well, thank you everybody for joining me. These are my disclosures. And it's hard to believe that in the not too distant past that some of our keratoconus patients had to function with a contact lens like this. This is a keratoglobus patient who had reported to my office a number of years ago, and he had already had a full thickness corneal transplant. And just for a moment, try to imagine yourself functioning in life with a contact lens like what he's wearing in his right eye. Well, thankfully now in the year 2023, we have the availability to fit this type of patient successfully in a scleral contact lens. And it is certainly a life-changing improvement for this patient. And, you know, it's interesting as contact lenses evolved for this particular type of patient, for the keratoconus patient, we went from mostly gas perm contact lenses to scleral lenses. And, you know, the real parameter change that has allowed us to fit many more patients is just scleral lenses have a larger diameter that allows them to be centered on the eye, more stable, more comfortable. And as you'll see, even in this lecture, they allow us to fit even the most severe keratoconus patients. Well, not too long ago, about 5 years ago, the SCOPE study team published some results in 2018. And it was a survey to scleral lens fitters, a little over 700 fitters. And what they asked them, what was their first lens option choice for fitting patients with corneal irregularity, which of course includes keratoconus. And interestingly enough, at that time, 44% of respondents were choosing corneal gas perm contact lenses versus 34% of respondents. Well, now the SCOPE team has some updated survey results. Again, this was a survey to over 700 scleral lens fitters, and we see these results have flipped. Now, 42% of the participants that were in the survey said that they were using scleral contact lenses first versus 20% for gas perm lenses. And the increased use of scleral contact lenses undoubtedly has helped many, many patients improve their quality of life. But we are also seeing that it's affecting the number of transplants that are done. And this is a study that was published by Dr. Karina Koppen, who's a Belgian ophthalmologist. And what they looked at was the severe keratoconus patients in their practice. And what they found was that specifically scleral contact lenses had reduced the need for corneal transplants. And I think just that study alone shows us the overwhelming benefit the scleral contact lenses have had for the keratoconus population of patients. So for today's webinar, my objectives are, number one is just trying to choose when we use scleral contact lenses for keratoconus patients, and scleral lens design considerations for keratoconus, scleral lens fitting keratoconus post-corneal transplant or penetrating keratoplasty. And then we'll talk a little bit about crosslinking and scleral lens fitting. And then we'll wrap it up with scleral lens optics for keratoconus, really keen in on higher order aberrations. Well, the title of the webinar is scleral lens management for the keratoconus patient. But of course, we know that keratoconus falls under the larger umbrella of corneal ectasia. And just to make everything clear, that this lecture not only pertains to keratoconus, but it also includes keratoglobus, pellucid marginal degeneration, and corneal ectasia post-corneal surgery. Well, first, I think one aspect of fitting a keratoconus patient in modern times is when the patient comes to our office and they need a contact lens for visual improvement, is choosing what type of lens modality to use. 25 years ago, 30 years ago, 35 years ago, it was just corneal GP lenses. That was really our choice. But now we have many options. And the first option is our soft contact lenses. Even for the form frus, the very mild keratoconus patient, you may actually be able to fit them in a regular molded, daily disposable, or frequently replaced soft contact lens. And in fact, actually, I had patients, and we'll see an example of this later, where they are so asymmetric with their keratoconus that in one eye they wear a daily disposable lens, and the other eye they actually wear a scleral contact lens. As the patient becomes more modern in keratoconus, we have the ability to lathe cut individual contact lenses, soft contact lenses, which allows them greater sagittal depth to fit steeper eyes, as well as we have extended power ranges, including a really high cylinder amount. So this type of lens, soft contact lenses, are still an option for patients with mild keratoconus. And then, of course, we have corneal gas perm contact lenses. And, for me in my practice, if a patient's already successfully wearing a corneal gas perm contact lenses, then I'm not likely to fit them out of it, especially if they don't have any problems. I reserve these lenses for patients that might have extreme difficulty applying a scleral contact lens. I'm big with piggybacking gas perm lenses for keratoconus patients. I think the soft lens, hopefully, if they can wear a daily disposable contact lens, not only improves the fit on many patients, but it certainly enhances the comfort. And it also acts to protect the cornea if we happen to have an area of bearing with that type of fit. Hybrid contact lenses are an option. I'm not really a hybrid lens fitter, but it is an option for patients with mild to moderate keratoconus. Probably not a great option for patients with more severe ectatic disease. And then finally, we're going to talk the rest of the webinar about using scleral contact lenses. In my office, scleral contact lenses are the default lens of choice for patients with moderate to severe ectatic keratoconus. Well, when we consider scleral lens designs for keratoconus, I kind of think about it in two aspects. Number one is we just need to vault the cornea. And actually, out of the two, that's actually pretty easy typically. That's the easier aspect of it. The area where we run into more science and art of the fitting process is really trying to match up the scleral lens landing zone design with the particular eye shape that we're presented with. And with that, in 2019, the scleral lens a study group published a paper in the Journal of Contact Lens Research and Science. And we were looking at a potential relationship with patients who have keratoconus and their scleral shape. This study was a retrospective study looking at 227 patients with ectasia, and we included 150 normals. And importantly, we subdivided the ectatic group of patients into patients that either had central ectasia or nipple cones, and those patients that presented with peripheral ectasia. And those would be apexes, corneal apexes that fell outside a diameter from center of 2.5 millimeters. All of these eyes had measurements taken with corneal scleral topography. And we really looked at two aspects of scleral shape. Number one was scleral toricity, and the second one was scleral asymmetry, or we would term as a quadrant-specific effect. For the quadrant-specific effect, specifically what we measured was we took and measured the sagittal height at the same axis as the ectasia, which is represented by the red X, at a core diameter of 16 millimeters. And then we took another measurement 180 degrees away, which is represented by that blue X, which is also at a core diameter of 16.5 millimeters. And we compared those measurements. Now, if you think about it, if a sclera has a shape of either spherical or it's toric, those measurements at the red X or the blue X, those are going to be the same because we have symmetry. If those measurements are significantly different, then that means that we have asymmetry, or again, what we termed as a quadrant-specific effect. Well, what were the results? When we looked at standard toricity for these eyes, we saw that on average, the eyes with the normal cornea, central ectasia, or peripheral ectasia all had about the same amounts of scleral toricity. So we have slightly less of scleral toricity average with the normal cornea, but then we just ramp up into the low 200s for both central ectasia and peripheral ectasia. And this is really useful and good to know. But where things changed and differed was when we looked at the quadrant-specific effect. And what we found for these cases was that for the normal corneas and the corneas with central ectasia, that they had insignificant amounts of asymmetry. So they were very symmetric on average. However, for the eyes with peripheral ectasias, they were on average highly asymmetric. In fact, the asymmetry averaged around 289 microns. And it's important to know that not only did we measure this asymmetry, but there's a pattern to the asymmetry. So, for example, this is a three-dimensional model of a keratoconus patient with an inferior cone, peripheral cone. And what we see here is that the pattern is that the steepest relative steepness quadrant of the sclera is in the same axis as the cone. So for this patient, she has an inferior cone. The inferior scleral quadrant is 300 microns steeper, or has 300 microns greater sagittal height than what we see in the superior quadrant. Now, these results were more or less correlated by a study that was published just a few years ago by Consejo's group. And what they found, similar to the scleral shape study group, was that using corneal scleral topography, the study found that the steepest regions of the cornea and sclera tended to share a common angle. In our study, in the scleral shape study group study, 90% of the decenter cones were inferior. That's probably not a surprise. And I think then what you might ask is, well, how does this affect the patient clinically when they wear a scleral contact lens? Well, a scleral contact lens wants to travel potentially to an area of less resistance or steepness. So in the case of an inferior cone, if the inferior quadrant of the sclera is relatively steeper, then the lens is going to want to slide down. And this isn't actually much different than what we see for a normalized or typical scleral shape, where with these patients, there can be potential asymmetry between the nasal and temporal quadrants. So for this patient, the nasal quadrant is very flat relative to the temporal quadrant. So the lens is going to slide temporally. And we commonly see this with our fitting scleral lenses on more normalized eyes. So if we go back to our keratoconus patient, it's predictable that if we put a scleral lens on her eye with a spherical landing zone, that we're going to get an inferior drop, which is what we see here to the right. And importantly, not only does this obviously negatively affect the fit, but a lens that drops inferior can actually induce positive coma. And we're going to talk more about that at the end of the lecture. Well, what can we do if this happens to help these patients have a better fit or more central fitting scleral contact lens? And the answer is that we need to fit them with a quadrant specific design. And that means increasing the inferior steepness of the scleral contact lens to better match that steeper scleral quadrant. How much? Well, if we look at the study data, on average, that's going to be between 200 to 300 microns steeper in the inferior quadrant. So if we go back to our patient, to the left is her eye with the spherical landing zone, and we have a decentered scleral contact lens. If we steepen up the inferior quadrant, then what we see here is a significantly improved, more central, better fitting scleral contact lens. Well, what about the keratoconus eye with the central ectasias? Sort of what's different about fitting that type of patient? Well, let's look at a case example. This is a patient I saw just a few months ago, 40-year-old keratoconus patient, central ectasia, clear cornea. He came to me for a scleral contact lens fitting. And this is his elevation map of his cornea. So this just shows that his cone, the steepness of his cornea is in the center. And we can predict from our previous study that he's going to have a sclera that is symmetric. Either it could be actually be spherical, but more likely toric. So if I overlap the elevation map of his sclera, what we see here is that we don't have a spherical sclera, but we have these areas of blue that are opposed to each other. Now, in an elevation map out onto the sclera, the blue areas actually represent areas of increased sagittal height or steepness. And so what we really see here is scleral toricity, and it is oblique in nature, and the steep quadrant is at that 30-degree axis. And in fact, actually, because we use corneal scleral topography, we can actually measure the specific amount of toricity, which for this patient is 286 microns. Predictably, for this patient, if we added a scleral lens with a spherical landing zone, we are going to get areas of edge lift where the sclera is steeper in that oblique meridian. And you can see here that that matches up perfectly with our mapping. And just using white light, you might be able to see just a little bit of trace edge lift there and some fluorescein underneath that I've added. But this is really highlighted with using the cobalt filter. So what we need to do in order to better match the landing zone for this patient's eye is fit them with a landing zone or a haptic with toricity around 250 to 300 microns. So that's what we did. For this patient, it's just basically designing a lens that adequately vaults over the cornea. I'm usually trying to vault initially before settling around 300 microns, and then adding, in this case, we know exactly how much toricity, so I'm able to add 286 microns of landing zone toricity. And right away, we have a lens that fits great for the patient, is comfortable, and that gives them a 20/20 vision. And I will tell you that out of all the patients that you might fit with scleral contact lenses, central cones, nipple cones, fitting them is probably one of the easiest types of fits. It's really typically not complicated because unless they have a pinguecula or something else that you have to vault over, the landing zone is going to be symmetric. Just to wrap that up, the patient or the eye with ectasia will typically have an average scleral toricity that runs somewhere between 210 and 220 microns. For eyes that have decentered apexes or cones, they are likely to have an asymmetric scleral shape. The average is around 280 289 microns. When you fit them, though, you can start with a sphere or toric landing zone. If that happens to fit great, then that's fine. You're done. You don't have to make it more complicated than it might have to be. However, if you're troubleshooting for a difficult fit where the lens is either decentered or you might have areas of edge lift, then you might have to consider a quadrant specific or freeform lens design. All right, next I want to talk a bit about fitting the post-PK patient. Penetrating keratoplasty is an option for some patients that have keratoconus. And the two major reasons to have a transplant would be because they have a corneal scar, which can commonly happen just with advanced disease or high drops, or they have an unwearable, they're unable to wear a contact lens, which luckily, again, with scleral lens use, that's becoming a thing of the past. Once a patient has a transplant, a full thickness transplant, there is a chance for the keratoconus to reoccur. And that can happen in approximately around 10% of patients over a 20-year time period. And there's two presentations to that reoccurrence. One is they can develop a central ectasia, or oftentimes what I see in my office is more a keratoglobus type presentation. And this is where the periphery becomes very, very steep. And when we approach these patients to fit them with a potential scleral contact lens, we have to use large diameters and large sagittal depths. So let's look at a case example. This is one of my favorite patients. Is a 58-year-old male patient with keratoconus that had a corneal transplant approximately 30 years ago. Unfortunately, to make things even a little bit scarier, he was monocular. He lost his left eye to a retinal detachment. He developed recurrent keratoconus after his transplant when he came to see me. And you can see how steep his cornea is. And I will tell you, if you are more of a beginner or even if you're a moderate type scleral contact lens fitter, these presentations can be a little bit intimidating. Well, the plan for him, of course, is to fit him with a scleral contact lens. We're going to need a large diameter with extreme sagittal depth. This is not the patient that you're going to fit with a corneal gas perm lens, or I would even argue a hybrid contact lens. This is a patient that truly will do best with a scleral lens fit. And so for this patient, I actually fit this patient before I was fitting from corneal scleral topography. So this was actually fit from a fitting set that I had that had a diameter of 20 millimeters. We use hyper decay materials so that we help prevent neovascularization to his graft, having increased oxygen. He sees very well. He's a high myope too, so it's lots of minus power, but he gets nice, good 20/25 vision. And sort of oddly enough, I guess the lens fits perfect with a spherical landing zone. So it's even though this eye looks complex, we didn't even have to do anything special with the landing zone here to get a great fit. But what I really want to point out is that the sag value to this contact lens is almost 8,000 microns. And just to put this in perspective, that's approximately double of what we might see for just a standard moderate keratoconus. So these eyes just need a lot of sag in order to vault from limbus to limbus and across that corneal surface. Okay, then I want to talk just a little bit briefly about pellucid marginal degeneration. It's, of course, a pellucid or PMD is a keratoconus variant. It's luckily pretty rare. You don't really see too much of it in clinic, but its classic presentation is that the patient has a very steep cornea that's paralimbal, really, really inferior. And that can make fitting tricky because we have to fit over just that one quadrant near the limbus. And so for this type of patient, if you run into them, a couple of scleral lens design considerations that you need to think about. One is you might have to go just a little bit larger in diameter. That helps expand that limbal zone, expand that vault. Also consider a lens design with a reverse geometry where the peripheral curve off of the base curve is actually steeper Generally, it's flatter, but in a reverse geometry, we can develop design a steeper curve, and that can help increase limbal vault. And then also, you may, for a more sophisticated design, or if you're troubleshooting, think about a quadrant specific limbal kind of backslash landing zone design. I'll tell you, I typically don't have to do too much extra for these patients, other than potentially a little bit larger diameter, maybe reverse geometry type of design, and they'll typically do well. Certainly, we get better centration for these patients using a scleral contact lens than we would with a corneal GP lens. As you fit more and more of these patients with a keratoconus, occasionally you're going to run into the patient with the ultra thin cornea. And I've certainly seen corneas that go down to around 100 microns, maybe slightly less. And then I would also consider just even up to 300 microns as really, really thin. Typically, the thin area is very localized, like in this patient. But if you haven't seen this before and this type of patient comes to you for a fitting, I think it can cause some concern. I mean, certainly even when I see this, I'm still a little bit concerned, because I think the fear is perforation of the cornea, and maybe if the patient wears a scleral contact lens and there's some suction pointed off, is that going to be what causes the cornea to perf? Well, the good news is the incidence of perforation with ultra thin cones, patients with ectasia, is extremely rare. And in fact, actually, when it does happen, it's usually associated with a hydrops event. So for me, if the patient is changing, then there's these sort of new techniques for cross-linking that can even cross-link super thin cornea. So that may be a consideration. But most of the patients that I see that present with ultra thin corneas are already in middle age or older, where we typically know that they're not changing. And so I just proceed to fit them with scleral contact lenses. This particular patient presented to me. She was in her 60s and lived in a small town, and literally was basically not fit with contact lenses, was blind for like 30 years. Finally went to the eye doctor. They sent her to our practice for a transplant, but the surgeon sent her back to me for scleral lenses. We fit her successfully. And when she walked out of her office, it was the first time she had seen in 30 years. So kind of a really great result, and helped that patient tremendously. After you fit patients with keratoconus and we're following them, we have to make sure that we don't see any changes with the fit or the design. This is a patient that I followed for years, a 44-year-old female patient, who came back to me as a kind of emergent visit, complaining of irritation. And we can see from the forcing pattern that her scleral lens now is touching the apex of her cone. And so at this stage, we need to try to figure out what's going on. Is the patient's ectasia getting worse, or do they have some longer late-term lens settling, which can happen as well? If we think that the cornea is getting worse or more ectatic, then we have to reevaluate the patient, of course, for cross-linking. This is another patient I just saw a couple months ago, another long-standing patient of mine with keratoconus. This is his left eye. He had also previous intacts in his cornea. He also complained and came in with irritation. And you can see from the OCT that we do have now a significant bearing of scleral lens right at his apex. And if you look to the right there, that's caused some epithelial disruption. Really fixing this is easy. You just, not much else has changed. You just call the lab and have them add an extra 200 to 300 microns onto the vault, and that will typically fix it. But then again, secondarily, we have to explore, okay, is this patient getting worse, and do they potentially need cross-linking? And that's a segue to cross-linking. And I want to touch a little bit about cross-linking with fitting. Remember, cross-linking is a dynamic sort of process. It's not static. You can see corneal changes up to 1 year. And there are factors or things that can change that affect scleral lens wear, including decreased corneal sensitivity for up to 1 year. We can have some corneal flattening for up to 2 diopters. And as you'll see here in a minute, we can see some scleral shape change. It's kind of an interesting study from the Visor group that looked at patients of theirs that were wearing scleral contact lenses that ended up going on to having corneal crosslinking. And what they found was that individual scleral lens fitting parameters such as scleral radius, scleral toricity, sagittal depth, base curve, and total lens diameter could change in 17 to 50% of cases at 1 year follow-up. And I actually had a patient like this that we published in Journal of Contact Lens Research and Science. 44-year-old patient of mine wore actually a soft contact lens in his right eye because his keratoconus was so mild. In his more severe eye, in his left eye, he was wearing a scleral lens with a toric landing zone. We thought his left eye progressed, so I sent him out for cross-linking, lost him to follow-up because he went to a different office for that procedure. But 3 months later, after the cross-linking, he called me up and said that he was unable to wear his contact lens anymore. It was irritating for his eye. Well, we had corneal scleral topography measurements before and after. And what we determined was that he had, after cross-linking, a significant asymmetric scleral shape change. And so in order to get him successfully wearing a scleral contact lens, we had to switch the landing zone design from a toric landing zone to a quadrant specific lens. And now he, again, over years of time, is successful and stable. And I have patients that come to me for scleral lens fitting, and sometimes they've had cross-linking and sometimes not. Sometimes, in fact, they've not even been educated about what cross-linking is. So we always have to look and to make sure that the patient is or is potentially is not a candidate for cross-linking first. And of course, some of those variables in that determination include how old are they, what is their vision, and of course, measured topographical change. And so my rule of thumb for these patients, if they show up to my office, is if we determine that they really are a candidate for cross-linking, if they're younger, they have topographical change, and they have pretty functional vision, then what I tell them is, okay, go get cross-linking first, and then 2 to 4 months later, well, we can fit you with a scleral contact lens. However, if they are a borderline candidate, maybe they're in their 40s or 50s, they don't have proven topographical change yet, and they have poor disabling vision, then typically I would try to proceed with the scleral lens fitting first, and then later educating them that if they need cross-linking, that may precipitate a lens change and a refit, just so that they know that up front. Okay, then I want to spend the last little bit of our time talking about aberrations. We know that scleral contact lenses correct lower order aberrations. They also correct, of course, and the reason we mostly fit them for the irregular cornea is to correct higher order aberrations. But unfortunately, especially for the keratoconus patient, we can have residual aberrations that affect the patient's vision. Scleral contact lenses, we know with keratoconus patients that they have this front surface irregularity. That's what we're masking with the scleral contact lens, but they also have back surface irregularity, and that's unique really for patient populations. In fact, of course, keratoconus patients can have back surface irregularity before they have front surface changes, and that's how we can catch them early. Well, scleral lens optics, as we know, standard optics only correct aberrations that are a result of front surface corneal irregularity. Luckily, front surface higher order aberrations typically dominate secondary to a relatively higher refractive index change as you go from the air to the corneal surface. But even with a fit scleral contact lens, we can have residual aberrations that are the result of back surface irregularity changes. And we can get residual aberrations not only from back surface corneal changes, but they can be lenticular in nature, either from the phakic lens or an intraocular lens, as well as we mentioned before, a scleral lens can actually induce residual aberrations, positive coma, by having a lens that's decentered. Well, what can we do for these patients? Because I will tell you that I have a lot of patients in my practice that are wearing scleral lenses successfully, but they are stuck at best visual acuity of 20/30, 20/40. Many of us now have aberrometers that allow us to measure aberrations, including residual aberrations. And the key, when we look at these plots, there's lots of types of aberrations, but I want you to remember that the real troublemakers are coma and spherical aberrations. Well, what can we do with lens design to correct for residual aberrations? Number one is we can add front surface eccentricity or an aspheric change. And then we'll also talk about more specifically correcting for aberrations using wavefront correction. Eccentricity can be manufactured on the front surface of a scleral contact lens that can reduce HOAs in a non-specific sort of uniform way. And if you add this to the lens, you can expect either reduction in vertical coma or spherical aberration. Just wanted to share this case with you. This is a 42-year-old female patient who reported to me. She had crosslinking in 2019. She was fit with a scleral contact lens from her local optometrist, great fit. But the problem is that she had reduced visual acuity with a scleral contact lens. This is her aberrometry measurements without a lens, and this is very typical. The eye has a lot of negative vertical coma, and this is what troubles her with her vision when she's trying to wear glasses. So this is a very typical presentation. This is her best fit scleral contact lens, 16.5 millimeter lens, normal sag, power a +2.25 gives her best corrected visual acuity 20/60 with a plano sphere sill overfraction. So this can be very frustrating, both for the patient, of course, and the doctor. How do we make this patient better? Well, when she came to me, one of the first things I did was also measure her aberrations using our aberrometer over top her standard scleral contact lens. And this is the result. What we see now is that she has significant residual aberrations, and a bunch of what her problem is positive vertical coma. Now, this plot represents a comparison between her right eye without the scleral contact lens, which is in red. Those are her aberrations before. And then the blue represents over top of the scleral contact lens. And what we see here is this coma flip. So her coma flips from negative to positive when she puts the contact lens on. And the issue with that is that these patients will typically neural adapt to what they are used to, which is negative coma. And sometimes they're not able to adapt well when we switch that over from negative to positive, as well as the amount of coma that she has is clinically significant, even residually, although she's wearing that scleral contact lens. So for this patient, what I decided to do is add some front surface eccentricity in an attempt to reduce those aberrations. So here's the results of that. The blue bar are her aberrations with the standard scleral contact lens, and the red bars represent her aberrations with the scleral lens that has front surface eccentricity added. And what we see here is a significant reduction in coma. So it doesn't flip the coma again, but it significantly reduces it. In fact, actually that green line really represents a subclinical amount of aberration. So we drop the positive vertical coma below what we consider subclinical. And what's exciting is this changes her from 20/60 vision and improves her now to 20/20 visual result. So for patients that we might consider eccentricity, the nice thing about adding eccentricity is that it's rotationally symmetric. We don't have to use a special type of lens design. It can rotate, and those results are going to be very similar when we add the eccentricity. Unfortunately, there's no algorithm to know how much eccentricity. So what I would advise you to do is work with your lab that you use, and they can help you along in this process. But sometimes, at least right now, it's a little bit of an estimated guess in how much you add. And again, as we showed, the nice thing about this is that it can significantly reduce vertical coma and spherical higher order aberrations. You don't need an aberrometer to do this. You can suspect it if the patient's 20/30 and just have the ad lab it. It's nice to see the before and after, but you actually don't need an aberrometer to do that type of correction, which is really nice. Now I'm going to talk to you about adding a more sophisticated type of measurement where we can specifically correct for individual aberrations, and that's with wavefront correction. We can use aberrometers to basically determine a wavefront measurement that gives us a detailed view of the refractive properties of the eye. And this can provide us a high resolution map that can be used to correct residual higher order aberrations of a fit scleral contact lens. The first step in that process is you have to fit a lens, and the lens has to be rotationally and transitionally stable. So it has to be something that's more customized. At a minimum, it has to have probably back surface toricity, and probably more ideally, it is freeform or quadrant specific. And then from there, it's a process of measurement, analyzing, design, and manufacturing that lens. If you want to learn more about this, there's many papers that are now published on aberration control contact lenses, including even soft contact lenses. But this is the paper that I always go back to and that I probably learned the most from. And this is an OVS article about wavefront guided scleral lens prosthetic device for keratoconus. So I encourage you to look that up if you really want to learn more in detail. I just want to go through a case example. This is a keratoconus patient of mine who came in for a fitting. His best corrected visual acuity in his right eye was 2400. We fit him with a 16.5 millimeter freeform scleral contact lens, power plus 13.25, gave him 20/50 vision. And so that's really poor. The reason he's so high plus is he had cataract surgery and they missed on the implant a little bit. So I advised him that we might want to, after aberrometry, to try to correct him with a wavefront guided scleral contact lens. So what we have to do is we have the lab remake a lens. They add some dots to it that we'll use for measurement and determination of lens placement so that we can decenter the optics correctly over the visual axis. So this is his aberrometry with a standard optic lens. His RMS value is 2.04, which is really high. In fact, average for the normal eye without keratoconus or eye disease is 0.33. So this is with his scleral contact lens, and it's certainly why he's seen 20/50 vision, and he has significant residual coma and spherical aberrations. So for this patient, we basically take the measurement. The lab adds the wavefront correction, which improves into 20/25. And you can see from those red circles that we had to decenter the optic quite a bit to get that sophisticated wavefront correction over his visual axis. But we had a really nice result at 20/25 lens design. This is his before and after wavefront maps, and just a very significant improvement here. So patients, that are candidates for this, certainly keratoconus patients fall into that category. Lenses that decenter, that can create trouble, so they might be candidates for that as well. We need lenses that are stable though, and that requires more sophisticated landing zones. And keep in mind too that sometimes patients don't always appreciate the wavefront corrected lenses or even eccentricity because they've neural adapted to what they had before. And I just want to end with this last case. This is a really interesting case that of somebody I just saw a couple months ago, 42-year-old male patient with keratoconus, left eye significantly greater than the right. His right actually is quite mild. He had always worn glasses and it did well with glasses, but he was now more interested in contact lenses. So this is his refraction. You can see just a little bit of a mild astigmatism for the right eye, 20/20, left eye, a pretty severe amount of astigmatism, but he does achieve 20/20 vision. So I said, great, let's fit you with scleral contact lenses. These are his aberrations without a contact lens on his right eye. Again, this is your typical significant negative vertical coma. His RMS value is root mean square, which is just, again, that's that quantitative amount of total aberrations. Isn't very high, and just a little bit double of what normal is. This is his left eye, looks really the same, but just more of it in a higher RMS value. And it makes sense because his keratoconus is more severe in his left eye. I fit in with scleral contact lenses, pretty straightforward fit. He was able to achieve 20/25 vision in his right and left eyes. Now, this is his right eye with and without the scleral contact lens. And so, like we have seen, the blue bars represent without the lens, the red bars with. We get this coma flip for this patient, and we significant amount of residual coma as well that goes to positive. This is his left eye, that same coma flip, negative to positive, and a very significant amount that's residual. Well, when the patient came back, he was unhappy with his vision. He's like, the lenses are comfortable, but I'm unhappy with my vision. Well, the reason he's unhappy is because he's dealing with a bunch of residual aberrations that he's not used to, that he hasn't neural adapted to. So what can we do for this patient to save it? Well, we could add eccentricity like we did for that first patient. We can have wavefront correction like we did for the second patient. Or because he sees well or saw well with glasses, we could consider soft contact lenses. If we consider soft contact lenses, the considerations are how much astigmatism are we going to have to correct, and what do the topographies look like? Well, keep in mind, this is a refraction. Very little astigmatism on the right eye, much higher amount on the left eye. These are his topographies again. A very mild form Frust-ish type keratoconus for his right eye and more moderate on his left. So he was sitting in my exam chair and I thought, what can I do right away to help him out? And so what I did was I just replaced his right scleral lens with a soft daily disposable lens, a trial set that I had in my office. And I put it on his right eye just to see what would happen. And he was 20/20 with that lens. And I said, well, okay, well, how are you doing now? And he said he was doing perfect. He loved his vision as soon as we put the soft lens on his right eye. So I had him go home with the contact lenses and saw him back 2 weeks later. In fact, that was just actually a week and a half ago, and he's doing wonderfully. He's doing great with his contact lenses now. So the take home here is that patients with keratoconus that have 20/20 visual acuity with refraction can sometimes perform better with glasses or soft contact lenses than they can with a gas perm contact lens, which includes scleral contact lenses. And this is just be careful what you wish for, because I also have a whole bunch of patients in my practice that are keratoconus that see 20/30 vision. So not perfect, because of residual aberrations, but they don't wear reading glasses. They're in their 40s and 50s and they don't wear reading glasses. And the reason for that is because some of these residual aberrations, including coma and spherical aberrations, can help them read. So if you correct for those, they might get a line better at distance, but then they have to wear reading glasses up close, which might make them unhappier than you expected. So just to wrap up, just with this ectatic population of patients, I encourage you to utilize scleral contact lenses. I think they really significantly help out many patients. The average toricity for the keratoconic eye is 210 to 220 microns. Scleral shape can be spherical though, so watch out for that. That can happen. Consider quadrant-specific designs or for peripheral ectatic eyes. Utilize front surface eccentricity or wavefront correction to reduce higher order aberrations. And lastly, just actually be cautious about adding front surface toricity, because sometimes patients want subjectively a front surface toric correction in the office because it's helping to mask some of their other aberrations. But if you add that and they come back, sometimes they won't like it later. So just be careful about that. There are patients that need and do better with front surface toricity, but be careful that's not just trying to mask other aberrations. And with that, I will take any questions that you have.
Oh, Greg, that was fantastic. Thank you so much. I personally have a question. So I've always wondered why keratoconic patients kind of defy the whole presbyopia thing. And that's amazing that you just kind of debunk that myth. I really didn't understand why. But is that effect lasting, like as the presbyopia progresses, or is it just a temporary thing?
Well, I will tell you this. This is funny that you asked that, because just today I have a keratoconus patient who's 60 years old, just turned 60, does not wear reading glasses.
Wow.
And so it just depends on the amount and possibly, the patient's situation, that type of thing. This patient's an engineer. But mostly I just see this all the time, that these patients don't require reading glasses. The better the vision, the less aberrations, probably the more the more they're going to require reading glasses. But those patients that are hovering around 20 or 30 or 20/40 actually usually do quite well up close.
Mhm. I've certainly seen that clinically. Can you just repeat what you were saying about adding the front surface eccentricity, like how you would do that just with a general lab without an aberrometer?
Yeah. So basically, what I would recommend is just working with your lab. There's various amounts that it runs somewhere. Probably you're going to add anywhere between 0.3 to 0.8 if you look at the literature. And again, unfortunately, right now there's no algorithm to say, okay, you have this aberration or this patient's vision. Start here, start there. The studies are kind of all over the place right now, and the funny thing about wavefront correction is it's not 2 + 2 = 4. It's really 2 + 2 = 6.7. And it can really stump you sometimes. And of course, I presented a lot of home run cases, strike cases. I have plenty of gutters too. And so it doesn't always work like you'd think. And sometimes we just really have no idea why.
Got it. Some of our viewers are asking, is the cost for their wavefront corrected lenses, is it a significantly higher cost than just a regular scleral?
Yeah, for the labs that are doing it, it is an add-on cost. It is significant. And I think it's, I won't go into pricing on a webinar like this, but it's significant. And beyond that, too, the other factor that you have to consider for yourself and the patient is just more chair time, because you're going through another two or a couple lenses at least, at minimum. And I think you just need to sit down and think, is this worth it for this patient? And they might do great, like the patient I presented, but I've had patients where no change or sometimes worse. And that's hard, when you go through all that extra work, potentially more cost, and the patient doesn't benefit. I'm actually more of a believer right now in eccentric changes because I'm seeing them work clinically pretty well, and it's pretty easy to do. It's a lot easier to do than adding true wavefront correction. I'm not saying that doesn't have its place. It certainly does, but I think eccentricity for this population of patients may have a lot of value.
Got it. And if you can mention, is adding the eccentricity, the front surface eccentricity, is that an add-on or is that not
No,
usual?
I mean, I can't imagine that would be an add-on.
Okay.
I can't speak for all labs, but it's a fairly easy adjustment for the lab to make. So again, I can't speak for labs.
Right.
I would be shocked if it was.
Okay. You've mentioned this, but I just have a listener that would like to know, how do you know specifically when to add eccentricity or wavefront to correct spherical aberration?
Yeah, I mean, if you have an aberrometer, you can kind of look at the residuals and say, and then combined with their visual acuity, if they're performing maybe like you wouldn't expect, considering the rest of their eye, they don't have corneal scarring or their eyes healthy. But again, as I mentioned, you don't have to have an aberrometer. If you have this patient that has a clear cornea, they're 20/30, 20/40, and everything else about their eye front to back is healthy, you can count pretty much on that it's residual aberrations, and you can just give it a try. And again, it's not a huge investment. You could just even try one lens just to see what would happen with them. And it could be worth your while.
Well, Dr. DeNaeyer, thank you so much.